Perfect. Thanks, Stefania.
Excellent. So yes, thank you very much for the opportunity to present today. So this is work that I've done at University of Southampton with quite a few of my colleagues that some are also on the call. So it's work that we've done looking at determinants of long sickness absence and economic inactivity among older workers. So you are all aware that population of Western countries are aging, and this includes clearly population of the UK. And people tend to, once they get older, they tend to have more comorbidities and ill health. And the UK government has implemented some changes, some policy changes to try and encourage people to work to older ages. And one of those policies is an increase in state pension age. However, it is possible that older people are unable to remain in work and work in a productive way at older ages because, as I said, they are more likely to have poor health and sickness. So the methods, both these analyses, for this analysis we use data from the HIF study, or Health and Employment After 50. This is a large cohort of more than 8,000 men and women that were recruited when they were aged between 50 and 64. And the recruitment took place in 2013 and 14. And the recruitment was done through 24 GP surgeries around England. And it was the GP practices who sent a consent form and a baseline questionnaire to all the patients that were in the required age range. And then people that wanted to take part, they returned consent form and baseline questionnaire to us. And then they were formally recruited in the study. And since then, they completed annual follow-ups, reporting on a variety of factors, such as the demographic factors, their finances, lots of variables related to health, health-related behaviors, and employment and caring commitments and unpaid work. Because the idea of the study basically was to look at exploring the associations between work and health in both directions. So the aims of the current analysis, so first of all, we wanted to quantify the independent contribution of health, lifestyle, employment-related risk factors to high annual sickness absence among this cohort of older workers. And secondly, similarly, we wanted to focus on determinants of early long-term economic inactivity. We wanted to see whether the determinants were the same or not. So looking at the first outcome, sickness absence, so quite a lot of research has been conducted, and the main determinants have been identified as, in terms of health, they are mental illness, such as anxiety and depression, and also musculoskeletal disorders. And in terms of work-related risk factors, a work that is physically demanding is a well-known risk factor, and also poor relationships with colleagues and poor employment conditions in general. And also there's been research looking at generosity of sick pay in relation to sickness absence, and the results are quite controversial. So in some cases, it's been found that more generous sick pay is associated with longer sickness absence, but this is not always the case. However, we felt that the relative contribution of all these components of factors, especially among older workers, was unknown, and that's why we conducted the study. So the outcome here is high annual sickness absence that we abbreviated with HASA. And this is collected at each questionnaire and ask the participant whether they can recall whether the previous 12 months, how many days they had off work because of problems with their health. And as you can see, they can tick one box, either no time, less than 5 days, 5 to 20, or more than 20. So we are not able here to look at single episodes and duration of each episode, but we're looking at the overall duration over the year. And we decided to focus on people that reported more than 20 days in a year, because we felt this was the most burdensome kind of length of sickness for the person and for the employer. And we compared this category with anything less than that. And the statistical analysis, so the units of analysis were follow-up intervals, and clearly each person has contributed to more than one follow-up. And to account for that, to account for the clustering within each individual, we use multi-level logistic regression, and you'll see the estimates as odds ratios and confidence, 95% confidence intervals. And also we started building a univariate model, and then we built a final mutually adjusted model with all factors that were significant at the initial stages. And as well as odds ratio, we computed population attributable fractions, or PAFs. And these are expressed as percentages and give you an idea of the proportion of the outcome, HASA in this case, that could be avoidable if we were able to remove completely that exposure. And in terms of risk factors, they could either come from baseline if there were things that were not going to change over time, or they come from the follow-up under consideration if we're talking about health, for example, or employment factors who can change at each follow-up. So the results, 8,134, this is the number of participants that were recruited in the HIF study. And of those, clearly for this analysis, we needed to limit the analysis for those ever in work, just over 5,700. And we had also to remove some participants, those that only had baseline, so no follow-up available, or those participants that didn't have usable follow-up because, for example, they changed job. We had to restrict the analysis to those that were in the same job because of how the question on the sickness absence was asked. So we asked them to report what happened in the previous 12 months. So if someone had changed job, we wouldn't really know whether the sickness absence was related to one job, the first or the second. So final sample, 4,700, very similar men and women, as you can see. And the outcome HASA was reported in 6.5% of follow-up intervals. And as expected, HASA was more common among women at older ages and more common among people that were coming from more deprived areas and working in manual or routine occupations. So here I'm showing the final mutually adjusted model. So all the variables that you see here, all these estimates are adjusted for all the other variables in the table, and also for sex and age. And there are 6 health-related variables here, and some employment-related factors. And the strongest ones and the strongest determinants, as you can see, are disabling musculoskeletal pain in the previous 12 months with an odds ratio of more than 3. And also unintentional weight loss in the previous 12 months, that is potentially an indication of another underlying illness. And in terms of PAF, as I said, so this 25 PAF corresponding to disabling MS pain. So if we were able to remove completely disabling MS pain, we would potentially avoid 25% of the high annual sickness absence. So that's quite a strong result. And also depression has a PAF of 11. And this is a physical demand of work. It goes in the expected direction. So working in either intermediate or high physically demanding work is associated with is a risk factor for high annual sickness absence. And this is the generosity of pay as expected. In our data, we found that a longer pay is associated with more sickness absence. And in here, we've replaced the 6 specific health variables with 2 health behaviors that were significant in the previous univariate model, BMI and smoking status. And we can see that BMI, so especially being morbidly obese, BMI more than 35 is associated with an odds ratio of almost 3, and also has a quite big PAF associated with that, while smoking status is not really a strong determinant. So to summarize these findings, so we found that musculoskeletal pain, depression, and high BMI were major causes of HAZA among older workers. And in terms of work-related factors, we found that working in a highly physically demanding work was a strong risk factor, and we also found an association with generous sick pay. And at the same time, we found factors that we were expecting in a way to be associated that were not in our data, such as job stress, that in this case we measured as reporting of difficult personal relationship with colleagues or frequently worrying about work. So we found a very weak association with that. And also job security was not associated with high annual sickness absence. So a few limitations and also some strengths. So as I said, because of how the questionnaire asked this question, so we had to exclude participants that had unstable employment, so those that changed jobs. And so as a consequence, those people are clearly more likely to experience more sickness absence. So it's likely that we have underestimated the PAFs. Our data were not affected by COVID-19 because the last follow-up that we've analyzed was in 2019, so before the pandemic. And we are talking about self-reported data here, but we have collected them prospectively, so we can make sure that exposures are preceding the outcome, the sickness absence. So if we want to try and lower the long sickness absence, we found that we should possibly tackle depression and musculoskeletal pain, and also try to reduce obesity. And also, if we've got older workers, especially those that are in poor health, if possible, we should consider whether they can be placed in a different job, a job that is less physically demanding, to allow them to be able to work for longer. And we feel that we need to conduct more work, needs to be conducted to be able to talk about sick pay generosity. We cannot really conclude too much here from this type of analysis. So this was the first outcome. So now I'm going to talk about the second outcome that we looked at is the early long-term economic inactivity. So in our data, we explored the first onset of early long-term economic inactivity that we abbreviated with LTE, and this is being continuously out of paid work for 12 months or longer before reaching state pension age. And this definition clearly it differs from what is used by the ONS, where they talk about a much shorter period, only 4 weeks. But because of our questionnaire, this is what we could do. And we, in terms of risk factors, similarly from the previous analysis, we treated them. We took them from baseline if they were not changing, or they were used as time varying. So for this analysis, we used discrete time Cox regression, taking as time intervals the period between successive questionnaires. And the estimates are hazard ratios with their confidence intervals, and we've stratified the analysis by sex. So the results, again, starting from the 8,134 participants, we had to make some initial exclusions. So we excluded all those that were already over. They had already reached state pension age at the time of the baseline questionnaire, and also those that would reach state pension age within 2 years. And also we excluded those that were not in paid work at baseline. And we were able to make some, to impute some dates. So people, every time they tell us whether they've, when they left the previous job and when they started the new job. And in several occasions, 469, we were able to impute based on other dates available, but for 51, we were not. So we had to exclude them. So final sample 3,400, very similar breakdown by sex. And these results corresponds to 11,000 follow-up intervals analyzed. And 682 individuals, almost 20%, reported the first LTA. So here I'm showing the association in terms of hazard ratios between LTA, the outcome, and a selected group of variables. And here we are among men. So you can see point estimates here and confidence intervals, and you also see a vertical line corresponding to hazard ratio of 1 that informs us as to whether the association is significant or not, statistically significant or not. And what we see here is that as opposed to younger men, those between, so men between 50 and 54 years of age, the older men were more likely to experience LTA. And then we have a series of financially related variables. So we see that those men that don't contribute much financially to their family income, they are more likely to experience LTA. And also those that do not need to pay either for their mortgage or they don't pay rent. And also we find an association with a private or employer's pension. So those people that either expect a private pension before their set pension age, or they are receiving the private pension already, they are more likely to go on and have an LTA. And again, another variable related to finances is men that expect their income once retired to be quite high, a high proportion of the current income. Again, they are more likely to experience an LTA. And then we have some slightly weaker association with unpaid work, like volunteering and being employed as opposed to self-employed. And also we find that being dissatisfied with work is a risk factor, and having slow walking speed, which is a marker of frailty that we found in a previous paper, being a strong risk factor for health-related job loss. And for women, the results are very similar, but the main difference is that we also see an association with marital status. So again, possibly this has to do with their finances. So women that are single, they don't live with a partner, basically, they are less likely to have an LTA. And the other factors are again related to the financial affordability, and very similarly compared to men. And we find just a couple of different things here. They are more likely to have an LTA if they are not coping with the physical and mental demand of job, while you see very weak association with disabling pain and no association at all with depression, and still the association with slow walking speed that we found in men. So to summarize, we found that the main determinants of LTA are related to financial security, and the associations are stronger among men. So things like eligibility for private pension, contributing less to family income, and expecting a small reduction in income after retirement, in addition to not having to pay for the home. These are all important risk factors, determinants for LTA. We found job dissatisfaction to be a work-related risk factors, and we found that physical demands and career responsibilities, especially among men, they are not really related to the outcome. And in terms of health, we found for men and women slow walking speed as an important risk factor. So some limitations and strengths, we don't know by the definition that we use, we don't know whether the person is actively seeking employment or not. So our definition, as I said, is different from what's used in other surveys, but still it's quite important. Our outcome is quite relevant to economic output. We are talking about people out for at least 12 months. And although we are aware that the HIV participants are quite a selected group of people, they differ, so the results cannot necessarily be generalizable to the rest of the population. We don't anticipate any bias in associations. We don't expect people to have answered differently in terms of the risk factors based on whether they had an LTA or not. And main strength, we have a prospective design, and we have demonstrated with a sensitivity analysis that I haven't shown that there was no bias due to missing dates. So the results were pretty much the same when we excluded people for which we imputed missing dates. And clearly the 20% with LTA, this is an underestimate of their lifetime prevalence. We are only talking about the first episode, so 20% is smaller compared to the prevalence that it's given in the official statistics. So to conclude, we found that determinants of high annual sickness absence and early long-term economic inactivity are very different. So economic inactivity is driven by financial affordability, and it's more common for people that are have higher levels of education, and they are working in occupations that are less physically demanding. Completely the opposite for sickness absence. This is more common for people with poorer health and poorer social circumstances, and also employed in more physically demanding jobs. And yes, I would like to acknowledge, of course, the HIV study participants and my team, the HIV team, and also all the co-authors. So as I said, Prof. E. Ramadan, I think, is on the call, and Dr. Giorgia Dani, and also Prof. David Coggon and Dr. Elena Zabaya. They all contributed quite a bit to this, and we discussed implications and methodology. And yes, I would like to just highlight that we have a study website for the HIV study. We've got lots of data available at several follow-ups. So if people are interested, please get in touch. And we've got, yes, this analysis contributed to 2 papers that are currently under review. So hopefully they will be published. And thank you so much for listening.
Stefania, thank you very much for a very clear presentation. That was a lot of